Thank you for this kind invitation, and good afternoon, evening to everyone. Can you see my presentation?
Yes.
Yes, I think it's okay. We can hear you. Thank you.
Okay, thank you. These are my disclosure in the last 2 years, and this is the outline of this presentation. I'll try to briefly address the clinical impact of diabetic polyneuropathy, the problem of wide underdiagnosis, how the guidelines can help in addressing this problem, then the pathway for screening and diagnosis of polyneuropathy, which indications come from the guidelines for clinical practice, and some suggestion for the strategy to implement guidelines. This is an Italian epidemiological study with a high number of participants, where the diagnosis of diabetic polyneuropathy, of small fiber polyneuropathy and painful polyneuropathy was based also on instrumental procedures to get a confirmed diagnosis. And the prevalence that we found of diabetic polyneuropathy was 36% in type 1 and type 2 diabetes, and a very low percentage of small fiber, isolated small fiber polyneuropathy, only 2.5%. And among the people with diabetic polyneuropathy, just a bit less than half had the painful form of diabetic polyneuropathy. In the whole population, 14%. More recent study from Denmark confirmed these two findings: 32% for diabetic polyneuropathy and around 40% for painful diabetic polyneuropathy. And also, when we look at the literature, we find a median value of prevalence of painful diabetic polyneuropathy of 15%, when the diagnosis was at least of the degree of certainty of probability, that is the presence of both neuropathic pain and signs of diabetic polyneuropathy. But as also indicated previously by Professor Odriozola, the diabetic polyneuropathy is also present in prediabetes, with a median prevalence of 10%. And in addition to this epidemiological burden, and also in addition to the impact of diabetic polyneuropathy as the main cause of foot ulceration, and then their complications as amputation, we have hard evidence that the presence of diabetic polyneuropathy and the positivity of measure of neurological measure of diabetic polyneuropathy are associated with an increased risk for all-cause mortality, as documented by this meta-analysis, with an adjusted heart hazard ratio around 1.6, greater in type 1 diabetes than in type 2 diabetes. Furthermore, we know that pain, neuropathic pain, is associated with an increased prevalence of symptoms of depression, as documented by this study, where the frequency of depression was 44% compared to 26% in people with non-painful polyneuropathy and 10% in people with diabetes and without diabetic polyneuropathy. And there is also a relevant impact on quality and quantity of sleep. And all these aspects, but in particular the presence of neuropathic pain, is associated with the increase in direct medical costs, indirect costs related to the loss of working days, social costs, and it is interesting that costs increase as the level of pain intensity increases, and also that costs are higher to patients, families, society as a whole than to the health system alone. So high impact for prevalence, high impact on morbidity and mortality, on quality of life, on personal, social and health assistance costs, but there is also a wide underdiagnosis of diabetic polyneuropathy throughout the world, and we have data, we have findings of percent diagnosed people with diabetic polyneuropathy between 62 until 82%. And this is a very recent survey in Europe to assess patients' perspectives and experiences, and to evaluate different aspects of life of people with neuropathic pain, who responded yes to at least 4 out of 10 questions of the DM4, that is a screening tool for neuropathic pain, to identify neuropathic pain, and we documented that it is very useful for the screening of painful diabetic neuropathy. And the result is that 50% of these people with neuropathic pain had not received a formal diagnosis of painful diabetic neuropathy, and 16 received a diagnosis of neuropathy but without pain. 22% did not receive a diagnosis despite informing the healthcare professional of their pain, and 12% avoided to refer pain to their healthcare professional. And this is a scenario not very satisfying, also in countries like Germany, the Netherlands, Spain, and UK. And what is then the role of guidelines in to address this wide underdiagnosis? And there is no universal acceptance of the positive role of clinical guidelines, and this is some sentences from a debate published on British Medical Journal 12 years ago about the value of clinical guidelines. And there was one extreme where they were considered an expensive, unhelpful, and ineffective toy for a happy few. And the other extreme was to consider a tool whose implementation has had a relevant impact on clinical practice and on patient outcomes, as in cardiovascular field. And a survey published always in 2010 among members of American Academy of Neurology assigned a high value to clinical practice guidelines. 82% of members considered important or very important guidelines. But which are the requisites that guidelines should have to be received, to be better received by the doctors? And this is another survey among doctors in family physicians in Germany, aimed to investigate the attitude and the experiences with regard to guidelines in general, not in particular guidelines related to diabetic neuropathy or to diabetes. And not all the people who participated to this survey were positive, were favorable to guidelines. Only 51%. But this percentage suggested that guidelines are associated with increased evidence orientation, standardization of diagnostic and treatment standards, that they can have positive effects on the quality of care, but implementation is also perceived as complicated. And then the conclusion of this survey were that guidelines should be practical and clear, and medical scope for action should be emphasized. The involvement of other members of the team, not only the doctors, should be promoted, and then the specific needs of who are skeptical or hesitant should be addressed in guidelines. And almost 2 years ago, in bit more than 2 years ago, there was a consensus conference on the diagnosis and treatment of diabetic polyneuropathy in clinical practice, with the aim to provide clear, comprehensive and practical recommendation and algorithms for the screening, diagnosis and treatment of diabetic neuropathy in clinical practice. Just to address these needs that in clinical experience and in literature could be found. And the recommendation of this consensus for implementation of guidelines into clinical practice were that guidelines should be clearer on diagnostic procedure, treatment choices, and follow-up to encourage adoption into clinical practice. That it is important to increase awareness and improve education about the disease among patients, emphasizing their role, and also among healthcare practitioners, physicians, and other stakeholders. That the screening can be also performed by trained staff such as nurses, educators, podiatrists, and may be incorporated into other screening and routine procedure. Before describing the conclusion on the screening and diagnostic pathway of these guidelines, just a few words just a few words on the diagnostic pathway. And as indicated by this review, we have different, and also anticipated by Ariel, we have different tools for the diagnosis. Evaluating symptoms and signs, scoring systems for these, or also for symptoms, quantitative sensory testing, or psychophysical procedure, functional objective methodologies as nerve conduction study, and morphological methods, in particular epidermal innervation using skin biopsy and corneal confocal microscopy. Nerve biopsy is very, very rarely used. And with regard to these scoring systems for symptoms and signs, I think that the most useful are the Michigan Neuropathy screening instruments in its questionnaire and in its neurological examination. But we also know that the sensitivity, at least of the questionnaire of Michigan Neuropathy screening instrument, is very, very low. Here we have a study by Danish people where the sensitivity and specificity of these screening scoring systems have been evaluated. And as you can see, the values are not very high for few of them, and the best performance is that of DM4 plus pain in the feet. What is the DM4? DM4 is a screening tool for the identification of neuropathic pain, for the discrimination between neuropathic and nociceptive pain, and is based on 4 questions. Actually, 2 questions are really questions on symptoms, and the other 2 questions are related to physical examination. And the sensitivity and specificity of this tool is very high, and also we documented that it is very useful for the diagnosis of painful diabetic neuropathy. When assessing neuropathic pain, both to decide the opportunity, the indication to treatment, and for the follow-up, it is necessary to quantify pain. Pain is a subjective experience, but it needs to be measured. Also, it is relevant to evaluate the impact of pain on quality of life. And in this field, there is an easy-to-use questionnaire, the brief pain inventory, that allows both the quantification of pain severity and also the quantification of impact of pain on different items of quality of life. And the actual modality to get a diagnosis of both diabetic polyneuropathy and painful diabetic polyneuropathy is based on the criterion of the degree of certainty of diagnosis. And this approach has been used by Toronto Consensus for diabetic polyneuropathy, and also by the International Association for the Study of Pain, so non-diabetological society, but neurological society. And for the diabetic polyneuropathy, the presence of symptoms, characteristic symptoms or signs reaches the diagnosis of possible diabetic polyneuropathy when both symptoms and signs are present of probable diabetic polyneuropathy, and with the contribution of nerve conduction study or skin biopsy or thermal thresholds for small fibers, the level of definite or confirmed diabetic polyneuropathy. For painful variant of diabetic polyneuropathy, the first point is to identify the neuropathic nature of pain that should be in a distal symmetrical distribution, and in presence of diabetes, this reaches the level of possible the painful diabetic polyneuropathy. When sensory signs are present in the same area of pain and with the same distal symmetrical distribution, we have a probable painful diabetic polyneuropathy. And when we can also add the evidence from nerve conduction study or small fiber function study, function or morphological studies, we have a confirmed diagnosis of painful diabetic polyneuropathy. In general, in the clinical field, we can stay at the level of probable diagnosis, and we don't need nerve conduction studies or the study of small fibers, but there are some conditions where the referral to neurologist for electrodiagnostic studies is relevant, when the presentation of symptoms and signs is atypical, as for acute onset, rapid progression, motor deficits, predominance, or asymmetric distribution, or proximal and multifocal distribution of symptoms and signs. And what the strategy of scientific societies in this field in face of this possible diagnostic pathway for diabetic neuropathy. The strategy was to simplify and to make affordable, suitable the screening and diagnosis in clinical practice. And then the recommendation from American Diabetes Association indicate the need for a careful history and assessment of one measure of small fiber function, temperature or pinprick sensation, and one of large fiber function, suggesting vibration sensation. Also in consideration that monofilament insensitivity is not early sign in the natural history of diabetic polyneuropathy, but the monofilament should be used to identify the feet at risk for ulceration and amputation, and then used annually. And also in the components of the comprehensive diabetes medical evaluation of American Diabetes Association, the evaluation of temperature, vibration, or pinprick, and the monofilament examination are included. What are the conclusions of the expert consensus that I cited before with regard to screening? That it is needed and relevant patient history that should consider the presence of neuropathic pain and its characteristics, but also the non-painful symptoms, and suggest that for neuropathic pain, DM4 or also a validated score for symptoms and signs can be used. And for diagnosis, the first conclusion is that the minimal criteria for the diagnosis in clinical practice are the presence of a bilateral impairment of vibration sensation or pinprick test, assessed with very, very easy tools. And the presence of neuropathic pain and signs of diabetic polyneuropathy in the same distribution is suggestive of painful diabetic polyneuropathy. The need to exclude other causes of polyneuropathy with at least the assessment of vitamin B12 and also electrophoresis is suggested, and the referral to neurologists were appropriate and with a typical presentation of symptoms and signs. This is the algorithm with a first step that can be enough in not well-served context. Symptoms and pain, pinprick, and diapason. And the need for differential diagnosis and the criteria for the diagnosis for painful diabetic polyneuropathy. It is also possible, of course, to add other measure of small fiber function or large nerve fiber function, as temperature sensation, touch pressure sensation, proprioception, ankle reflexes, and also the possibility to use quantitative sensory testing, of course. And in front of the wide underdiagnosis, there have been different attempts to offer some solution, and one solution has been that of consider the best combination of different steps in the neurological examination in terms of time spent and also the ease of the test. And this is a study from China, where the combination of ankle reflexes, thermal and vibration sensation assessment worked the best. And another more recent approach to reduce the burden of the population with diabetes to screen for diabetic polyneuropathy has been the development of systems to stratify the risk of polyneuropathy. And risk equations, nomograms, deep learning models have been developed with the main requisite to be exclusively based on clinical and demographic variables, such age, BMI, or weight, glycated hemoglobin, blood glucose, triglycerides, HDL, LDL, or smoking, or others easily accessible clinical variables, and with the caution that it is not clear so far the applicability of these algorithms, and also the need to validate these algorithms in a population different from that from those where the algorithms were developed. But this approach can have, I think, some future to identify the people at higher risk to develop diabetic polyneuropathy. And another strategy has been developed in UK, in Sheffield by Solomon Tesfaye, and it is based to the combination of annual eye screening and screening also for microalbuminuria with DPN and diabetic foot risk screening. And it has been shown that it is feasible with a high uptake, very well received by participants and staff, and this approach is also recognized by the National Health Service, is financed by NHS in UK, and was awarded an innovation award. But one point that at the end of this brief conversation I want to highlight is the need of a good communication between patients and physicians. This is a survey in Southeast Asia about the patient and physician perception of painful diabetic polyneuropathy. And just some results of this survey. One result is the fact that physicians considered the diagnosis of painful diabetic polyneuropathy a low priority compared to that of other diabetic complications, and the incidence of screening was very low in these countries, and that there was some differences in belief between physician and patients. For example, physicians believed that painful diabetic neuropathy had a greater impact on quality of life, but patients believed that painful diabetic polyneuropathy had a greater impact on sleep, anxiety, depression, and work. And both physicians and patients agreed that it was patients who initiated the conversation on painful diabetic neuropathy. There is the evidence that physicians do not ask patients about the presence of pain. And thus it is very important that the awareness about painful diabetic polyneuropathy can be increased in patients. And so the conclusion of this study is that the physician-patient dialogue is central to maximizing patient outcomes, and then strategies, including education, need to be developed to improve communication. That's my conclusion. Diabetic polyneuropathy is highly prevalent. early, associated with the burden in terms of complication, qual, and costs. And there is, in front of this epidemiological evidence, a wide underdiagnosis, also in different contexts throughout the world. Screening and diagnosis in clinical practice is based on symptoms and signs with simple procedures, and the role of guidelines is recognized in giving evidence-based and expert indication for screening and diagnosis, but we need practical and clear diagnosis. Doctors ask for this, and innovative approach and strategy might be required to implement guidelines and address the wide underdiagnosis of diabetic polyneuropathy. Creativity can be play some role in this purpose. And I thank you for the attention, and again for invitation. And I just remember the next meeting of annual meeting of Neurodive in Thessaloniki at the end of September, and also the possibility to send abstracts until the 10th of May. Thank you.